Well, welcome everybody to our Dementia Genetics webinar. I am so excited to have everybody here with us, and I am incredibly excited to have Eric Collett and Randy Vawdry from A Mind for All Seasons join us to give their incredibly valuable input regarding prevention for dementia and Alzheimer's and what you can do to help minimize your risk. So I'm Lindsey McCormick. I have founded the Maryland Center for Brain Health out here in Maryland. I don't know where everybody on the webinar is coming from, but if it is as hot where you are as it is where I am, I feel for you because it is about 105 degrees out here and I am roasting. I don't know. How is it in Idaho, Eric?
Oh, it's about the same,
Yeah,
at
it's
least in
been
the Boise area, triple digits.
pretty toasty all over the US. So I'm excited to have people from all over coming here. And I founded the Maryland Center for Brain Health this year in order to help people sort of get control over their lives, get their lives back in regards to dealing with neurodegenerative diseases such as dementia and Alzheimer's, also traumatic injuries, car accidents, concussions, things like that. So my goal is to really help people know that there is hope out there and that there are things that we can be doing to help not only prevent dementia and Alzheimer's, but also help to sort of stop it in its tracks. So Eric Collett and Randy founded A Mind for All Seasons out in Idaho and created this incredible protocol called the Enhanced Protocol that's based off the research of Dr. Dale Bredesen. Eric is a nationally recognized dementia expert. He has worked in assisted living communities he's a licensed residential care administrator, and he's also a teacher at BSU and the College of Western Idaho. Randy Vawadri is our nurse practitioner for Mind for All Seasons. He has extensive experience in the hospital, skilled nursing, psychiatric care, primary care settings, and he is the chief architect of the enhanced protocol that you are going to hear about today. So, why did we want to talk to everybody about dementia genetics? And I think this is such an important question because it's one of the things that I hear about most frequently when we start talking about family history of genetics, family history of dementia and Alzheimer's, and different types of dementia. And a lot of times people get very, very concerned, when you start talking about the Alzheimer's gene, whether somebody has it or not, whether it runs in the family. And a lot of times, they say, I really don't want to know. There's nothing that can be done about it. What can we do? I would rather just live my life in peaceful bliss. And if it happens, it happens. There's nothing we can do about it. So if you want to go to the next slide, Eric, I really love this slide because it's very indicative of a lot of the thought processes surrounding, dementia and genetics right now. A lot of people, like I said, they don't want to know. They just want to bury their head in the sand, pretend like these problems aren't happening because there's nothing that we can do about it. But obviously, we wouldn't be having this webinar if that was the case. So I'm really excited to talk about a lot of the ways that knowledge is power. And when you know what's going on in your body, what your genetic risk is, you know how to take control of that and you know how to change your future. For instance, somebody that has the ApoE44 gene, which is known as the Alzheimer's gene, that is a gene that helps to express a lot of inflammation in the body. This can be a strength and this can also be a weakness. So if your body produces a lot of inflammation when you get injured or you get sick or you get ill, that's a good thing because what that does is it helps to heal you, it helps to fight off infection, and it helps to make you better quicker. On the flip side, if your body has a lot of inflammation, it tends to store it, it has a difficult time getting rid of it, and that can accumulate, especially in the brain with the amyloid plaques that can lead to Alzheimer's. So it's really good to know what your genetics are so we know what to utilize to help combat them. People, you don't have to think that you're doomed just because you have the Alzheimer's gene. That's what we're here for.
This whole question of genetics is really interesting, Lindsey, because so many people that I've helped do genetic testing over the years have decided for good reasons that they wanted to get tested, and they've come back and they found out that they were an ApoE33, for example, and they said, oh, that's so great, I don't have the Alzheimer's gene. Well, first of all, there are probably hundreds of genes that influence our tendency toward Alzheimer's. ApoE is just the most common one that we talk about. So it doesn't mean that they don't have other genetic factors. And sometimes they look at me kind of funny when I say, oh, you're a 3-3. Well, you may be a little bit less likely to have Alzheimer's disease, but you may be more likely to have Parkinson's disease or to have problems related to toxicity. It may be that your body's detox pathway doesn't work as effectively as it should. And maybe you can't mount as robust of an inflammatory response as if you did have an ApoE4 allele. So to your point that there's kind of a strength side and a weakness side to every genetic tendency, just because you have one gene or another doesn't mean that's cause for celebration or feelings of defeat. One of the main takeaways in the presentation today is we want people to understand that understanding your tendency gives you power to be able to address it. When you understand how these things influence your body, you can make different kinds of decisions.
That's such a fantastic point, Eric, that you really do have control, and we want to help you give that control back. So I like this slide because it's sort of analogous to when we talk about Alzheimer's and dementia and prevention. If you look at cancer, if somebody gets diagnosed with cancer or they go to the doctor and they find a tumor, even before that stage happens, people are already thinking about what can I do to prevent cancer? What can I do to stop this from even happening in the first place? And there's tons and tons of research out there about all these different things that we can do to help prevent cancer. Breast cancer screenings, self-breast examinations, mammograms. If they find something, you can get it biopsied, ultrasounds, vaccines, cervical cancer screenings, colon cancer, lung cancer. There's all these different screenings, chest x-rays, colonoscopies, so many preventative elements that we can do in regards to cancer. Why aren't we thinking about that in regards to our brain?
Yeah, so we jump in early when it comes to cancer prevention because we really want to do something about it. We jump in the earliest stages. Look at this cancer screening guideline. Randy, I think you were the one that found this.
Yeah, I was thinking as Lindsey was talking about this, how many times I've met with patients, specifically Medicare clients, for their wellness consults. They come into the office and they say, I'm here for my wellness exam, and I need to do a little bit of blood work, and I need to get my mammogram, and I need to get my colonoscopy, and I need to do all of these things. And in their mind, they're thinking, how can I prevent disease in the long run so that I can stay healthy? And I've never, ever in the history of my practice had someone come in on their own volition and say, I'm here for my wellness exam and I want you to check my brain function, right? That we're not conditioned to do that. Now, I've had people come into my office and say, my brain is not working well and I need you to help me figure this out. But I've never had someone come in on a prevention wellness say that. So it is very interesting.
That's kind of out of the box from the way that we normally think, isn't it?
Mm-hmm.
Yeah, hopefully in the future, you will start to get more of that, more of those people coming in and wanting, this preventative avenue to happen with their brain health.
Oh, I hope for this all the time. And actually in my practice, I'm having more and more people come in saying, hey, I've heard you speak at the Alzheimer's Association meeting, or I heard you give a lecture at this venue, and it really got me thinking I'd like to test my brain function. And it's happening earlier and earlier. I want to give you an example of how distorted I think our world is when you compare how aggressive we are at prevention for cancer and how lax and how kind of irresponsible we've become as a medical society on testing and preventing dementia. And I'll give you an example of this, okay? I took this from, I think it was actually just a graphic. I did a Google search on staging of cancers. And I was trying to find a really simple graphic that showed, okay, when you hear someone say, I've been diagnosed with cancer, almost without question, people say, oh, what stage was it? What type of cancer was it? And I don't even think people know what that means when they ask what stage it is. So I thought, I'm going to give you an example of how we stage cancers, and then I'm going to compare that to how we actually stage dementias. and I'm hoping it will induce a lot of deep thinking. So a stage 1 cancer is a very small localized mass or lesion. And oftentimes we think of stage 1 breast cancer. That's where the mass or the tumor is only in the breast tissue and it's in one clearly defined, clearly demarcated tumor. It hasn't spread to the lymph nodes. It hasn't spread to the regional tissue. It's just one small defined cancer. And in many cases, we call this ductal cell carcinoma. And I've actually read a lot of discussions online that many believe this to be a precancerous lesion. Like some would even suggest it's not even cancer. It's a precancer lesion, kind of like you might have a precancerous skin lesion on your face. But if you had a precancerous skin lesion on your forehead, like I have this little scab because I went swimming this weekend and bumped my head on the pool, we address those. We get after it. We go in and have them burnt off with liquid nitrogen, or we biopsy them and cut them out. So we're aggressive. Stage 2 would be still a localized cancer that it hasn't spread to the additional tissues. And then stage 3 and 4 are how aggressive does this expand into the surrounding tissues or spread throughout the body. And that's a terrible word in cancer we call metastasis, okay? Now I want you to imagine if I'm your primary care doctor and you have a stage 1 breast cancer and I said, Lindsey, don't worry, this is just stage 1 breast cancer. It's not even a very big tumor. Don't sweat it, teeny tiny, hasn't traveled anywhere. Why don't we just leave it alone for a year? You come back next year at your wellness visit and we'll see if it's gotten any bigger. Okay,
Yeah.
Lindsey, how would you feel if that's what I said to you?
That would be terrifying.
Wouldn't it be irresponsible on my part if I did that?
Absolutely. Yes.
And you would say,
Incredibly.
what are you talking about? I want to get a mammogram. I want a diagnostic ultrasound. We're going to do a fine needle biopsy. We're going to stage this baby. We're going to try to figure out if it's hormone sensitive. And I want to know if I need to have a lumpectomy, if I need to have my breast removed. Do I need to do chemotherapy, radiation? I mean, you would just give me the what for on how to address that cancer. Okay. Now, I'm going to shift gears and say, let's talk about how we stage dementia. Stage 1 dementia would kind of be like stage 1 cancer. It's preclinical. Most people have no symptoms, but we are certain that the underlying pathology of dementia is there and it's progressive. In fact, we know that by the time dementia is diagnosed, you've probably had it for 20 years.
At this stage, Randy, is anybody showing any symptoms at all?
Most of the time, no. Most of the time, they have the risk factors for dementia, and many people don't even know what those risk factors are. Okay, so stage 1 would be, I don't really know that I have dementia. I'm 40 years old, but this disease is a little bit more progressive, maybe because I have a family member that has dementia. Maybe I was a smoker for 10 years. Maybe I'm insulin resistant or pre-diabetic and I don't eat very good. So all of these things end up being dementigens, right? I don't know if you've heard that word, but it's kind of similar to the word carcinogens, that there are precursors that lead to dementia. If we're not careful, it starts forming. We don't even know it, just like a breast cancer would be. Stage 2.
If I can just jump in real quick. In some cases, people will have brain fog, and obviously not every case of brain fog leads to dementia. But it's kind of like not every lump in the breast is cancerous either, but we still take it really seriously. And I think what you're suggesting, Randy, is when someone has brain fog, that's not normal brain functioning, and we need to take it more seriously than we do. So if there's
For
a symptom,
sure.
that's probably what shows up.
You know, stage 2, we call it subjective cognitive decline. That term subjective in medicine means it's not measurable, but the patient says it's a problem. Kind of like pain, right? We've been told that pain is the 6th vital sign. If someone says they have pain, you don't say, no, you don't. You say, well, tell me about that pain. Where is it? How aggressive is it? Is it a 4 out of 10 or a 10 out of 10? When did it start? How long has it been there? Okay, that's what we need to do in subjective cognitive decline, or stage 2 is when someone says, man, I am foggy and I don't this is weird. I can't remember things like I normally could. I feel like I can't find the words. I see people when I go to church and I recognize their face, but I can't come up with the name. It's taking me longer to do tasks that I would normally do. This is subjective, and this is where patients complain of a little bit of slippage. And you know what? We do just the opposite in medicine. Someone comes in and we say, nah, I think you're okay. It's probably just in your head. Maybe you have depression.
Or
We
you're
don't
just stressed.
validate that. Yes, you're just stressed out. And even the patients, Lindsey, will say, Gal, you know what? I think I had too much alcohol last night. I had a terrible night's sleep. My mattress sucks and I can't get a good night's sleep. So that's why I'm brain foggy, right? Well, listen, people had better pay heed to that. That's a stage 2 dementia. Stage 3 is where we can actually measure it. We can actually do some testing, some of it very sensitive testing. Others are just kind of general screens like MOCAs and mini mental status exams. And we can actually measure there is some cognitive decline. And at the point at which we say, wow, you're really impaired, this is a dementia. The reason I point this out is I want our audience to recognize that just like cancers, by the time that someone has been told they have dementia, it's like stage 4 metastatic cancer. It is progressive and it has been there a long time. And it takes a lot of energy to try to combat it. Okay. But look at the difference. In stage 1 cancer, we have all kinds of screening tools, all kinds of diagnostic tests. We talk about it at every wellness visit, early detection, biopsy pathology, and then we offer the smorgasbords of treatment. Let's take that lump out, start chemotherapy, and do 5 treatments of radiation. And in stage 1 dementia, we don't even talk about it. We don't talk about stage 2 unless a patient brings it up. And stage 3, I can tell you for a long time in my practice, when someone says, man, I'm not feeling 100%, sometimes I didn't even do a MOCA score because it would take me 20 minutes to do. And I think, oh my goodness, I don't have time to do this. This is hard. I'm not proud of that as a practitioner, but trust me, I've mended my evil ways. And I recognize now how important it is when someone says, I'm not feeling 100%. I wonder if something's not right. I am all over that. But in traditional medicine, we don't even address dementia until it's stage 4, which is the equivalent of metastatic cancer, very advanced. We need to start very early. We definitely need to start in stage 2. We need to gather a history and we need to do some very specific labs. And Dr. Bredesen has been brilliant at subtyping these dementias. Subtyping means that all dementias are not created equal. They don't form under the same precursors or clinical measures, and we can oftentimes identify trends and risk factors based on some of these labs and their history. And then just like we do with cancers, just like we do with diabetes, we should start implementing lifestyle coaching, dietary guidance. Oftentimes we recommend supplements. And you might think, well, what good is a supplement going to do in dementia? Do you know that the only drug that has been approved for the last 20 years, or the first drug approved for dementia in the last 20 years, was donepezil, or there's rivastigmine and galantamine. These medicines improve the transport of choline in our brain. And so an easy supplement would be choline. Now, it's not treatment for, but it is supportive for, the same way that we use supplements to support other issues. Many people out there have high cholesterol and they take omega-3s. It's not necessarily treatment, but it is supportive. And then detox has a little bit of that woo-woo feeling in the world of conventional medicine, but there are very good things that we can do that strengthen our liver function, and it strengthens our ability to send toxins down to the sewage, either through our bowel movements or through our urine and so forth. And I don't think we have time to talk about those today, but these are things that can be employed very early on. They're very safe and they're very supportive for someone who might have a little bit of cognitive decline. Do you guys have any thoughts or questions or comments about what we've talked about so far?
I'll jump in, Randy. I think one of the interesting things on this current slide that's up right now comes out all the time with people that I talk to. People say, yeah, I just have mild cognitive impairment. The name itself is really a misnomer. By the time someone has what gets labeled mild cognitive impairment. It's anything but mild. We're
Right.
talking, they have been dealing with cognitive decline and some underlying pathology for 10 to 20 years. And I really think that it deserves a different kind of a label, or at least people need to understand that by the time you have a diagnosable condition, there's a lot of damage already done, and we should be jumping into action at that point.
Yeah, Dr. Bredesen actually did a webinar on a podcast, and I love it. I've listened to it several times. And he says exactly what you said. Mild cognitive decline should actually be called late-stage Alzheimer's disease. There's nothing mild about it. It is very advanced. And what we call Alzheimer's disease really is end-stage Alzheimer's disease. That is no wonder the whole world is scared of Alzheimer's disease and doesn't want to talk about it. And it's because the only time we're conditioned to talk about it in traditional medicine is when it's end stage. No one's willing to even have a discussion about it earlier on and talk about preventive things that we can do that make a difference.
Isn't it
Exactly.
interesting that Alzheimer's disease is nicknamed in the medical world diabetes of the brain, or type 3 diabetes? And when it comes to diagnosing diabetes, it's exactly the same sort of problem. At least in type 2 diabetics, we wait until it's end stage metabolic shutdown to diagnose it, when really, if we were tracking things like fasting insulin over time and recognizing that all that weight gain that a lot of these people are experiencing is related to metabolic mayhem that's going on, we wouldn't diagnose it so late. So interesting.
Lindsey,
parallel.
what would you add to that?
I agree. I think that I love what you're doing in your practice. And, I was just thinking about, every wellness physical that I've ever had, and not once has my doctor ever asked me, how's your brain doing? Are you having any issues? It's just not something, even I think as people get older, it's still not a question that is really asked. And so I think that if people can start to have the knowledge and the power to go into their physician and not just brush it off, and not just say, oh, it's some brain fog, but I've been tired and, moving on, but maybe actually really start to look into, the trends and, how long has this been going on? And physicians can start to learn and start to ask some of those really pertinent questions.
Yeah, Lindsey, when you were speaking, I don't know why my mind wandered back when I was in nursing school. This has been 25 years ago. And I remember getting my first blood pressure cuff and my first stethoscope. And I would go to all my family members and I'd say, can I check your blood pressure? I got to practice this. Can I listen to your heart? And I want to listen to your lungs. And I got really good at using my diagnostic tools to identify the variability in people's blood pressure and their heart sounds and their lung sounds. And it wasn't too long ago in my practice that I started taking MOCUS tests and mini mental status exams and going to all of my friends and seniors and saying, you know what, I've been working on trying to prevent dementia. Would you mind if I did a MOCA test or a memory test? It'll only take 15 minutes. Do you know how many of seniors turned me down?
A lot.
Actually, none.
Oh,
They
really?
all said, oh my gosh, I'm
want it?
kind of nervous because my memory's not very good. I'm a little self-conscious, but yeah, why don't you? And it blew me away how many individuals scored far lower than I thought they would have scored, because they didn't think they had any dementia, and I didn't think they had dementia, but they did not score near as well as I thought that they would score. And that's where we get back into this. I feel like I almost need to be a nursing student again and run around with my stethoscope and my MOCA test doing these little screening. And I bring that up, Lindsey, because you've had so much experience in the physical therapy world specific to assisted living centers. And I have visited with marketing directors of assisted livings, and I've asked them, what percentage of people living in your community do you think have the early stages of dementia? And one of them said, well, I think only about 25% have dementia. The rest of them, they're crystal clear. And I thought, oh my goodness, no, I think it's probably the opposite of that. I think it's probably about 80% have many of the early signs of dementia, and maybe 20% are crystal clear. Eric, what's been your experience? You've run assisted living centers before.
Yeah, I think there's actually research on it, and the numbers are somewhere in the neighborhood of 70 to 80% of people that are living in assisted living have at least some sort of diagnosable cognitive decline. So I totally agree with you. But the
Yeah.
whole paradox of dementia is you don't remember all the things that you're forgetting. So you lack
Exactly.
insight. And clearly it's not just about memory loss. It's, executive dysfunction and trouble with manipulating numbers and orientation and on
Mhm.
and on and on, all the things that the brain does. So it can't just be about memory problems, but so often people lack insight. And there are many things that we test people on regularly that don't come up in everyday life. And when people are living alone, they get into a routine. They may be in the same house that they've been in for the last 40 or 50 years. And so they've kind of got their routine down, and family members think, oh, yeah, they're fine. They're totally independent. Look at them. And I can't tell you how many hundreds and hundreds of times I've done tests with people in front of their family members and watched the jaws drop because they had no reference point to be able to discern the kinds of problems that come out in testing. It's a pretty fascinating thing.
Eric,
I
I
was
just recently, oh, Lindsay, go ahead, and then I'll add
I
an
was
experience.
just having that exact conversation today with an administrator who was talking to me about their independent living population, not even assisted living, but independent living, and how many of them have significant dementia, but because they have their own room and they have that comfort and that familiarity of their own room, when their family members come to visit and they visit them in their room, they seem fine. It's when you get them out of that environment, they can't find their way to the dining room. They can't find their way to the front desk. They don't know where they're at. They get lost going back to their room. But the family members don't get to see that because they're not, they're really just visiting with them in their room. So, I mean, absolutely, there's so much of that going on right now.
Wow, what an
Yeah.
interesting experience. That's something that I haven't experienced, right? Because you're right. Most of the time, I do visit people with my clients in their room when I go to an assisted living center. I wanted to share a thought about why I think this often happens. I was recently asked by a client to write them a treatment summary, and I said, "Well, let's do your lab work." And they said, "Well, you can do my labs, but I do not want you to tell me if I have the gene for Alzheimer's." And my response was, "Well, why not?" And she said, "Because I could not bear the stress. And that would just worry me." And so I think one of the reasons that we're not more aggressive about staging dementias is that historically there's been no good answer. And
Hmm.
so why know if you're in big trouble anyway, right? It's like if there was absolutely nothing we could do for cancer, why do a mammogram? And I think that our audience needs to understand that there are so many things that could be done to prevent the advancement of a dementia. And according to this guy that we have on the screen, Dr. Bredesen, he would say that there are many things that you could do to actually unwind the confusion. Eric, do you want to talk about that for a second?
Yeah, absolutely. There are so many things that people know and understand and have understood for years that impact brain health in good ways. Everybody knows that diet has some sort of impact. There's a lot of disagreement over what the best kind of diet is, but everyone realizes that the kind of fuel that you put in the tank dictates how the engine runs. Everybody has heard that exercise improves physical functioning. Everybody understands that certain medications can have side effects that cause real problems. Most people realize that if you have serious nutrient deficiencies, like B vitamin deficiency, or you've got a major D vitamin deficiency, those things are going to show up in terms of your cognitive functioning. The trouble is when you test each one of those things, none of them is a cure for Alzheimer's disease. Dale Bredesen has done all sorts of research for about the last 30 years, largely trying to figure out medications that could be used to positively affect Alzheimer's disease or even prevent it. And over time, one of the things that he and his colleagues realized is that Alzheimer's is extremely complex, and there's not just one pathway that causes a person's brain to start having tangles and plaques and all the characteristic symptoms of Alzheimer's. They realized that it's a signaling problem and it's affected by many different things. And so rather than testing things in isolation, they recognized that maybe a multimodal approach would have more of an effect. Maybe it's kind of like the scales of justice, and there's not just one thing that tips you toward cognitive destruction. Maybe it's a whole bunch of different things. I think it's fascinating that we've learned in the last couple of decades that the part of the brain that controls memory, which is where Alzheimer's disease tends to start, actually produces between 700 and 1400 new brain cells every day. It's very neurologically active. There are stem cells there. And so how do you get to the point that that part of the brain on an MRI is shrunken and shriveled up and in the 1st to the 15th percentile? Obviously, you have to lose brain cells faster than they're being formed. So it's kind of like the scale tips. And back in 2014, Dr. Bredesen and some of his colleagues at UCLA at the Buck Institute started asking, well, what would happen if we measured all of those different factors that we know affect brain health, measure nutrients and hormones and inflammatory markers, and look at lifestyle factors like diet and physical activity and sleep and stress management and socialization, all of which have things that have come out in the research. And what if we developed a personalized plan for each individual? What would happen? Well, he published the results in a paper that he titled Reversal of Cognitive Decline, a Novel Therapeutic Approach. That's an amazing title, Reversal and Cognitive Decline in the same breath. And yet that's exactly what they found. 9 of the 10 patients had a reversal of symptoms. And for one of the participants, it even showed up on an MRI. He went from the 17th percentile in the volume of the memory center of his brain to the 75th percentile. And it was verified with a repeat MRI at a different lab. Well, that's unprecedented. And he's followed up with a number of research studies, including one that was recently published that was a much more controlled IRB-approved study. And that one showed 83% of participants had significant improvement. So Dr. Bredesen has popped out in the last several years with bold statements and has said Alzheimer's should be as rare as leprosy or polio. When is the last time you met anybody with leprosy? It's quite a statement for a researcher to make. And yet there are now thousands of people who have gone through this type of multimodal approach. Dr. Bredesen compares a brain to a roof, and a brain with Alzheimer's is like a roof that's leaking. And it's not just one hole, there's about 50 potential holes, and everybody has 10 to 30 things on that list. And so his approach is kind of like measuring the holes in the roof and setting about patching them all at the same time to whatever extent you can. Now, Randy, you and I have done this with hundreds of people now over the last several years, and we see amazing things all the time. I couldn't claim that this is a cure. I could definitely say that when we intervene early at the point that someone has subjective cognitive impairment or mild cognitive impairment, almost always they can turn those symptoms around and get normal adult scores. But I'm surprised how many times we've seen people with pretty advanced cognitive decline, advanced dementia, who've had major improvement in their scores. It's been remarkable.
Yeah,
so
we never use the word cure. We never use the word cure, and we don't use it in cancer either. We use the term remission, right?
Yeah.
And in dementia, I think that we can say maybe your dementia is in remission, or maybe we notice some cognitive improvements, because the nomenclature is tricky. And one time someone criticized me, I can't believe you're talking about that because you're just giving people false hope. And I'm like, no, actually, I'm giving people hope. There's nothing false about it. And I was on a telephone call today with a fellow from Arizona. His wife's MoCA score went from a 16 to a 20. And he said to me, you know what, her MoCA score got better, but I'm not necessarily seeing it in her short-term memory. And my response to him was, well, look, every time I take my kids to see my parents, they say, oh my gosh, I can't believe how big Daisy is. She is just growing like a weed. And I chuckle because she's Daisy. I see her every day and I don't see those incremental changes. But we can see those incremental changes on testing, and people do make improvement. So Eric, your point was, how do we refer to that? Do we refer to it as cure? No. Do we refer to it as mission? Well, that's not traditional either. How do we refer to it? Well, I think we say we've slowed the cognitive decline, and we actually are starting to get a little bit better. And that is not real common in the world of dementia, and it's certainly not common in the world of pharmaceuticals.
Yeah, absolutely true. I think part of the takeaway for our audience from all of this is that in cancer, if someone's doctor says, hey, you've got a pretty rare form of cancer, there's an experimental treatment out there. We really don't know if it's going to work or not, but you're terminal otherwise. And we're going to do everything that we can. Most people are like, sign me up for the
Sign me up.
study, do whatever you can. And with
Right?
Alzheimer's disease, it's exactly the opposite. Alzheimer's is a terminal illness, and people show up. We wait until they're in end stages of this disease to diagnose it. And then literally, doctor after doctor after doctor tells people, well, I'm so sorry, you have Alzheimer's. There's not much I can do for you. I could give you a prescription. They really don't work all that well. You might have to watch for some nasty side effects, but basically, that's your options. Why don't you come back in 6 months and I'll let you know if you're any worse. And all we're saying is we cannot make any sort of promises, but there is really good evidence emerging. And it's not just from Dr. Bredesen. You've got Richard Isaacson at Cornell University that's doing Alzheimer's prevention clinics, and he's using the same multimodal kind of approach. Daniel Amen at the Amen Clinics is doing a multimodal kind of approach. You've got the Share's Eyes at Loma Linda that are doing similar kinds of things, and we could add to the list. The bottom line is, I think what this slide shows, there are 100 billion brain connections, give or take a few billion, and every choice that we make either supports brain health or it's deleterious. And when we help people intervene by doing lab work and trying to make better choices, there's not a guarantee, but certainly if we do nothing, things aren't going to get better. And if we don't try, then the answer is always a door slammed in the face. The worst that we might expect is that we could get someone exercising more and maybe be a little bit more metabolically healthy. Maybe we calm some inflammation, they don't have so much joint pain. And even if cognitively they don't improve dramatically, maybe we help them have a better life experience for whatever time they have. So one of the things to pay attention to is the fact that with all of those billions of brain cells and synaptic connections, things influence us in significant ways. So the time that we go to bed and the time that we get up has a huge influence on us. If we exercise or not, if we had caffeine or not. Do we smoke alcohol and wreck our detox? I said, do we smoke alcohol?
Smoke alcohol.
I obviously smoked something. No, do we drink alcohol and deplete our glutathione levels and mess up our liver functioning so that it's harder for our body to clear things that we're all exposed to that are dementigens and toxins to the body? Do we have sleep apnea that's not treated very well? I met with a guy just this morning who had sleep apnea for, they're estimating somewhere in the neighborhood of 20 years. And he talked about how differently he did within 2 weeks of getting a CPAP properly fitted and adjusted. And then he said, what I wasn't prepared for was how much better I felt 6 months later. 6 months of really good oxygenation at night just changed his world in such a positive way. So clearly there are a lot of other choices, but every choice we make related to our body affects not just our gut health and not just our joint pain, but the human body is a system, and every choice affects the system, including our brain and all of those nerve connections in our brain. So are we supporting cellular growth or cellular death? Are we becoming smarter and more coordinated? Are we seeing improvement in our memory? Or are we just accepting memory loss as a normal part of aging? I don't think we should. I don't think it's normal, and it's not okay to consider major cognitive decline as just part of what happens when you get older. We should be much more serious about how we treat it. We can control a lot of the switching mechanisms in how our brain functions. We can, to get real technical, we can go down the SIRT1 pathway, which is like flipping the switch toward growth and longevity, or we can go toward the NF-kappa B pathway, and things aren't so good when we go down that road.
I like
Dr.
those
Bredesen,
those slides, Eric, because I think they really show to like the neuroplasticity of the brain. I mean, I don't know about you guys, but when I was a kid, my parents always told me, don't do this, don't do that. You're going to lose your brain cells and they never grow back. And like, that was what I was always told. And that's not the case. They do. And if you stop, drinking or smoking or eating poorly, or you start exercising, your brain has that ability to regenerate, and those neural connections can reform again. And I think that that's really powerful.
Yeah, absolutely. So this slide is obviously pretty technical. It shows a receptor that is related to Alzheimer's disease, amyloid precursor protein. The sticky plaques that form in the brains of Alzheimer's patients are made of amyloid beta protein. And you'll notice that it's like a switch. You can flip it one way towards synapse growth or one way towards synapse destruction. And when it gets flipped the wrong direction, that amyloid precursor protein gets clipped into 4 fragments. And one of those fragments is amyloid beta protein. And it just starts to build up in the brain. There are a lot of factors that cause that. It really goes beyond the scope of our discussion today. But one of the key takeaways for people is that we have some control over how this switching takes place. And as scary as it might be to know you've got a family history of Alzheimer's, or even to know your ApoE status, it's also empowering, because I've heard Randy and others say many times, genetics loads the gun, but your choices pull the trigger. And if you know you have a tendency toward one pathway, but you're making a lot of choices to counteract that, then you're going to probably have a very different experience than if you just buried your head in the sand and ignored it. Randy and Lindsey, do you have any other thoughts before we kind of continue forward and wrap up our discussion today?
I just want to mention that before we started the webinar, Lindsey mentioned that someone reached out to her and kind of gave her a hard time, suggesting that you can't really make a difference and you can't slow the disease, you can't alter the disease. And it made me sad to hear that, because that clearly is spoken by someone who doesn't understand the disease process and has no idea what causes it and how it progresses. And it also couldn't be further from the truth. There is so much that could be done in very early stages and even in late stages to help improve someone's quality of life. And I'm one that believes it's never too late to try to make someone's life better. And it's almost absurd for someone to say there's nothing you can do, because all you got to do is Google, how do I prevent dementia, or how do I treat it? And the first thing you'll read is exercise and eating better improves your brain function. Right. So I just want our audience to know, God, there's so much that could be done. And it just depends on how aggressive do you want to be.
Yeah, absolutely. Now, we don't have to talk too much about amyloid beta, but I do want to point out that there are a lot of drugs, including this latest drug that the FDA controversially approved, Aduhelm or aducanumab. And it and many other drugs that have been tested over the years are designed to actually get rid of amyloid beta protein. The challenge with that is that nobody has been shown to improve when you get rid of amyloid beta protein in the brain. And in fact, a significant number of people actually get worse. Could it be that amyloid beta is kind of like a white blood cell? When people get sick, we notice that their white cell count goes up, and we know that that's their immune system. But if we mistook correlation for causation, we didn't recognize why that was happening. And instead, we just noticed, oh my gosh, every time you get sick, your white cell count goes up. And we said, we need to make a drug that will get rid of those excess white blood cells. Imagine what would happen. It would be devastating. Well, there's research out there like that from Dr. Rudy Tanzi at Harvard that points to the idea that amyloid beta protein is antimicrobial, and it may be part of the immune system in the brain. There's still a lot that we're trying to figure out about that. But if it binds to toxins, for example, let's say you've got lead in your brain or mercury in your brain, both of which are highly toxic. If amyloid beta is produced to bind to those dementigens, and you get rid of the amyloid, but without the underlying cause of why it was produced in the first place, it stands to reason the person's going to get a lot worse and their experience won't be great. So amyloid beta buildup seems to be a response to bad signaling in the brain. So instead of looking at the symptoms, we want to look at the root causes. Lindsey, I know you love this picture. What are some of your thoughts about this image?
Um, I mean, I just love it because it shows that, I think a lot of people, when they think about the brain, they sort of disengage it from the rest of the body and they don't realize that what you do to the body affects the brain and vice versa. And when we start looking at all of these different factors that can really contribute to cognitive decline, brain fog, just the different disease pathways in the body, by fixing a lot of stuff, our inflammation, our stress, our poor gut health, our lack of exercise, not sleeping well, stress, by starting to take care of a lot of these things one by one, we really start to improve, what's happening within the body. And that really starts to show itself in the brain and starts to, fix a lot of the things that we're starting to experience up there in regards to cognitive decline. And it's all connected. And I think we just really need to remember that. And as you were talking about in the last slide with, just trying to get rid of the amyloid, we're just trying to fix the symptom, right? We're just trying to get rid of, the thing that is a result of everything else that's happening in our body. But you know, you can keep getting rid of it and keep getting rid of it, but it's always going to come back because we've never addressed what is causing it in the first place.
Hmm. Yeah, let's not treat symptoms. Let's treat the root cause of things that we're dealing with, regardless of what it is that we're dealing with. And let's promote wellness instead of waiting until people are ill. I think that's one of the things that's broken overall about our entire healthcare system. We wait until someone feels horrible, and then they go to the doctor and they want an easy fix. And so many of these lifestyle diseases are things that people live with sometimes for decades. And that's not a great way to live. I think there's more that we can do to promote wellness instead of just treating illness.
Yeah, we have to be more proactive versus reactive.
Yeah. All right, Randy, any thoughts on this slide?
Nope, I agree with everything that you've said.
Yeah. Okay, great. Well, one of the things that we have to look for when, as far as reasons that amyloid builds up, is that a person may lack the nutrients and hormones that are really supportive for brain functioning. The brain needs the right kind of soup, so to speak. Imagine trying to call something minestrone soup that should have all sorts of good stuff in the broth, all those vegetables and beans and noodles and so forth. And what if it was just broth? I mean, you really couldn't call it minestrone anymore. And the brain is a little bit like that. There are a lot of ingredients that have to be there for it to work optimally. So we've got to look at those things. Alzheimer's by nature is an inflammatory disease. And so we've got to look at markers of inflammation and do everything that we can to calm those down.
Eric, I do want to interject something here that as I look at that screen, sometimes I think of people who say, well, they studied copper levels in dementia, and when they repaired it, it didn't make a difference. And they've studied estrogen and dementia, and it didn't make a difference, which actually that's not true. It has made a huge difference.
Yeah.
And they've studied omega-3s, and it didn't improve cognitive function. Lindsey, do you know why that each of those individually didn't make a difference, and yet here they are on our screen about preventing the production of amyloid?
Yeah, because individually, it's just not enough. You have to look at the system as a whole, and it's like Eric's analogy of patching the roof. If you just start taking some omega-3s and you still got 50 holes in the roof, it's not going to do a whole lot. So you really have to look at everything else that's going on and then come at it, not just piecemeal it one at a time.
Yeah, so that individual that came to you and said there's nothing that you can do, well, the first thing you could do is say, well, why don't you just test for everything that you see on the screen, and anything that's suboptimal, let's optimize that and see what happens. Man, people's energy comes back, the brain fog seems to go away a little bit, and naturally it depends on where they're at in the disease process, but these things can make a difference when they're done in concert.
Yeah, I think we often treat our cars better than we treat our bodies. If I took an older car to the mechanic and said, hey, I'm going to try to make a cross-country trip here, and I want you to go through it and find anything that's going to cause me grief, and I already know that the water pump is giving out, and I'm leaking antifreeze, and my brakes are squeaking, so be sure and look at those, but I want to know if anything else. What if they came back with a laundry list of 25 things, and our response was, well, why don't you just change the brakes and maybe make sure that I have plenty of coolant there. Just top it off
Right.
and I'll take my chances. It would be ridiculous to try one or two things and then complain that it didn't work. And yet that's what we do in the human body, which is a far more complex system than an automobile. It just doesn't make any sense when you view it from that perspective.
That's a great analogy,
point.
Eric.
So, Randy, you talked earlier about different types of Alzheimer's disease and Dr. Bredeson's work in kind of subtyping this. You and I have seen this a lot, and Lindsey's seen this as we've worked with various people, and we've tried to identify root causes of their decline. There are different things that show up in the labs. Some people really seem to predominantly have a real inflammatory style to their Alzheimer's disease. For other people, there's a strong glycotoxic component. They're really insulin resistant. They're craving sugar. It's like they're overfed and undernourished. We see that a lot with people. Some people are really lacking trophic support, we would say. It's an atrophy style dementia, meaning they don't have the nutrients and hormones. It's like their minestrone soup is down to broth. Other people, though, are younger. They look like they're super healthy. We've seen people that were marathon runners or heavy exercisers that look the picture of health, and they're young, and yet they've got early onset Alzheimer's disease. That's a totally different kind of presentation. And when we do lab work with them, we find out, oh, they've been exposed to herbicides and pesticides and plastics and heavy metals and Lyme disease and other toxins that just really wreak havoc in the brain. A lot of people have a vascular component to their dementia. And then we see people that have had head injuries. And we might nickname this kind of a dazed dementia, where they've just been knocked around. And that triggers some chronic inflammation. It may be associated as well with toxic buildup, but it's definitely a unique subset of how they present. So we don't even, we meaning the general medical world out there, typically doesn't ever look at these kinds of subtypes. They wait till someone is a cognitive disaster, and then they say, oh, you got dementia, sorry. Save your money for long-term care, because that's where you're headed. And we're so cavalier about it. And in reality, when we dig into these labs, there's so much that we can understand about the root cause kinds of issues, which leads us to a lot of confidence as we've done lab work and we've applied interventions and we've used these kinds of techniques. We have seen over and over and over the ability to change the trajectory of a person's decline. What does that mean for people? Think of the gap that's there. If we can level things out, even if someone doesn't get much better, think of what that means for people. There's a lot of financial reasons to do that. There's a lot of quality of life reasons to do that. We can't change the fact that we're all going to die at some point. But if we can influence how we live in the meantime, that matters to a great many of us. Oftentimes, we've seen improvement in cognitive functioning. Randy, you mentioned earlier someone you were just talking to today who improved their MoCA score by about 4 points. That's substantial. We've seen people improve their MoCA score. It's not only,
it's huge, especially when your starting point was only 16 out of 30. That is very advanced disease. Yeah. And now to go to 20, I mean, I have just listening to how well this individual was doing with diet and exercise and sauna therapy and supplements and so forth. I have every reason to think that she can continue to make improvements up to the mid-20s.
Yeah. I mean, that is significant. In the therapy world, we get really excited if somebody can improve their MoCA score by one point. Like that, yeah. To us, like that's just a dramatic change, and that's fantastic. But for somebody to improve it by 4 more points is really, really exciting.
Lindsey, that's the difference of this individual not having to go to a memory care and being able to dress themselves and eat breakfast and follow simple directions every day. They still need verbal cues at this point in time, but they're trending away from the memory care, not trending towards the memory care, and it's amazing.
Yeah. Sometimes people worry about the cost of intervention, which really doesn't cost that much. But so many times we see people where life becomes less expensive for them as they become more functional. It's the people living in memory care that are at the highest level of care and they come down to maybe the lowest level of care. Maybe they still need memory care, but they're functioning a lot better. Or the person that goes from assisted living back to independent living because they're doing so much better. Or someone that spends a few $100s a month, and yet they improve so much that they avoid spending $5,000 to $10,000 a month on long-term care. The average lifetime cost to care for someone with Alzheimer's disease is between $340,000 and $350,000. And that's an older estimate, and healthcare costs are doing nothing but skyrocketing. So there's a lot of intervention that could be applied at a teeny fraction of the cost of the overall lifetime expense to care for somebody. So every reason to try some of these things. So it ends up being preventive maintenance. What can we do if we have a family history? I know a lot of the people that signed up for this webinar may be concerned about a family history of dementia or Alzheimer's, or they may be concerned that they have a known genetic risk factor. When it comes to prevention as well as intervention, we like to use this acronym of BEDS. And that reminds us that brain training is important, and there's good research on that. By itself, it's not a game changer, but it has its role. Then there's exercise, and there's dietary interventions, and sleep, and stress, and supplementation, and being aware of and dealing with evidence of toxicity. We call it the daily 6. And we could get into some of the details about these things. Time probably doesn't permit a whole lot of detail here, but Randy and Lindsey, any thoughts about BEDS plus T and some of the takeaways for people?
I mean, I think it's a great way to sort of remember the simple and easy things that you can do in combination to really help your brain on a daily basis. And it doesn't have to be these massive undertakings. It can just be a little bit at a time. You just start eating a little bit better. You just start adding in just a tiny little bit of that exercise. And then as you start to see improvements, you're able to do more and more and more. But it's a really great way to remember what's really important and what you can be doing on a daily basis to really help improve your brain function.
And I would add to that, Lindsey, sometimes people will say, well, which one of those are the most important? And I'm like, well, it depends on the person. Some people really need to focus on diet, but they exercise like crazy. Other people never exercise, but they eat really clean. So you really have to look at these individual interventions and help kind of coach a client through where do you need to spend your time and energy and what's your priority.
Yes, everybody's different, and each, that's why I love our personalized roadmap reports, because it really gets into the nitty-gritty of what is going on with that particular individual and what do they need to focus on.
Yeah. And to those points, people ask all the time, how is the enhanced protocol different than what Dr. Bredesen does? Well, Dr. Bredesen's research and the RECODE protocol are the core of what we've done here. They were the genesis of this, but really what we've done is to build a coaching program around it with all the tools and systems and processes and guidance to take something that is relatively complex. In fact, for many people, it's supremely complex. And we break it down into very personalized coaching that looks at where someone is and figures out, well, how do you need to eat? Instead of worrying about and arguing over what the perfect diet is, we acknowledge that diet's going to be different for people. If you're a heavy exerciser and you're 35, you probably need to eat a little differently than an 80-year-old that's been sedentary for the last 40 years and needs to lose 200 pounds. So we really have to personalize things. And these last few slides talking about this BEDS acronym and this preventive maintenance program kind of speak to some of the areas that we have to look into and explore to help people optimize their brain health and their overall physical system. So if we were to sum up the enhanced protocol and all the different interventions that we do, it would be a slide that looks like this. And that just seems crazy overwhelming, but we love this slide because so many people say, there is nothing that you can do for dementia. And then we flash this slide and say, well, here's all the things that you can look into. Well, let's talk about the research on any one of these things. Now, Randy, you were the genius that put together this slide in the first place. Do you have any thoughts about your mindset in putting this together, or what you wanted to convey that maybe I haven't even addressed yet?
The crazy thing is I put this slide together for me, not for anyone else. And it was so that I could walk into a room with a client or on a consultation like this and visit with the client and then quickly look at all of the interventions and try to figure out, what am I missing? What haven't I looked at? What could be done? If the patient's getting better, what could we do to keep that going? If the patient wasn't getting better, what's the stumbling block that I might be missing? And, fortunately, Eric, we've automated this now. So we've got some software that automates this entire process, so we don't have to rely on my two neurons firing trying to figure this out. But it really should illustrate to those out there who wonder if there's anything that you can do for Alzheimer's disease. There is so much that could be done to strengthen people.
These are all the holes in the roof, the potential holes in the roof that we can patch.
Exactly. Very well said. Well, let's wrap up here for today. Great discussion. Any closing thoughts, Lindsey and Randy? And
I really just want to thank you both for coming on. This was a fantastic discussion. I hope that people really learned a lot and really got some helpful tips on things that they can do to help sort of prevent this cognitive decline that's happening. And, we're here for you. Give us a call if you are even, just remotely starting to experience brain fog, or you have concerns about your genetics. We can help you navigate those waters. So give us a call.
Wonderful. All right. Well, thank you so much, everybody, for watching. We appreciate you taking time out of your day to learn a little bit more. Hopefully, this has been insightful. And like Lindsey said, we encourage you to reach out to the Maryland Center for Brain Health. Lindsey does great work there, and we're excited to support her and be partners with her in offering the enhanced protocol to people all over the country. So have a wonderful rest of your day, and we'll hopefully talk to some of you very soon.
Thanks, guys.
Thank you. Have a good night.